Hello, this talk is going to be on imaging of appendicitis. So, when we talk about imaging of appendicitis, I think sometimes people have the initial reaction, why do I need to talk about this? Because when it's easy, it can be a really easy diagnosis, and maybe we don't need a 30-minute lecture to tell us how to do it. But the flip side to that is that when it's difficult, it can be really difficult. So in this talk, I'm going to try and concentrate on some of these more problem scenarios and how we can sort it out and make a diagnosis. So what we're going to talk about today, a little bit about diagnosis, the pitfalls in making a diagnosis of appendicitis, where we tend to make mistakes, and then I'll finish with just a little bit about pregnancy, since that can be a sort of difficult circumstance when we're trying to make a diagnosis of appendicitis. So when we're trying to make a diagnosis of appendicitis, obviously what we're trying to determine is there appendicitis or not? But also we want to know, is it complicated or not? So let's start first by looking at some CT signs that can help us with those two questions. So the best sign for making a diagnosis of appendicitis is simply appendiceal enlargement. It is the most accurate sign. However, accuracy is obviously going to depend on where we set our threshold for defining enlargement. If we set it at 6 millimeters, we are going to overcall appendicitis in a large number of cases. If we set it arbitrarily, just sort of doubled the number at something higher, 12 millimeters, we're going to miss a lot of cases. So it's accurate if you use the right number. So what is that? Now this is an important point, and I'm actually going to put it aside for a moment, and we're going to revisit it in a few minutes because I want to go on and talk about some other signs of appendicitis now, because when these are present, the exact size of the appendix tends to be a little less important, as these can help support the diagnosis. And the first of those is periappendiceal inflammation, which we see here. You've got a biggish appendix, and we see fat stranding, fluid right around the appendix. We can feel quite confident in making a diagnosis of appendicitis. Wall enhancement. We see here that the wall is enhancing much more than adjacent bowel loops, a sign of inflammation. That in combination with some appendiceal enlargement, great indicator of appendicitis. Appendiceal wall thickening. This tends to be one of my less favorite of the secondary signs of appendicitis, just because there's quite a range of normal thickness to the appendiceal wall, like all bowel, anything up to about 3 millimeters for single wall thickness can be normal. Thicker than that is abnormal. But occasionally, in combination with a large appendix, a useful indicator of inflammation. Now, a sign that I don't think gets quite enough attention that can be very useful is the appearance of airless, low attenuation fluid in the lumen of the appendix. This is actually, you would think that you'd see it quite commonly in the appendix. There's fluid in bowel, there's fluid in the colon. Why can't there be fluid in the appendix? But you actually see it rarely in the normal appendix. It's less than 1% of cases where you're going to have airless fluid. Here's a nice example of an appendix, not very big. It was about 7 or 8 millimeters, but there was this airless, low attenuation fluid filling the lumen of the appendix. On the basis of that, we were concerned that this could be early appendicitis, and that was subsequently proven at surgery. Now, this number that has just popped up on the radiologic right side of the screen, the left-hand side, 2.6 millimeters, refers to the diameter, not of the appendix, but of the fluid. If you just measure the width of the fluid in the lumen of the appendix, if it is greater than 2.6 millimeters, that had a very high correlation in patients with acute appendicitis. Now, the number itself I find sort of ridiculously specific. I mean, it's pretty hard to measure something to, the 0.1 millimeter with much accuracy, but the general principle is important. that it's not just looking for airless fluid in the lumen of the appendix, but the more fluid there is, the more distended that appendix is with fluid, the more likely that patient has acute appendicitis. You can have less than 2 millimeters, a little 1 or 2 millimeters of fluid in the lumen, and that can sometimes be seen in normal patients. Here's another example. This patient had airless low attenuation fluid in the lumen of the appendix in the setting of acute appendicitis. Sometimes this appearance can actually help draw your eye to the appendix, can help you find it in the first place. And you note in this image that sometimes the fluid in the lumen actually looks lower attenuation than the fluid in adjacent bowel loops. Now, to some extent, this can just be a visual trick, just because the wall is hyperemic, so the fluid next to it looks a little lower density. But sometimes it's actually true if you put a Hounsfield unit measurement on it, and it's probably just due to a slightly different composition of the fluid, an obstructed appendix with some mucus retention and stuff. It can drive the density of the fluid down a bit. Here is an example of a normal appendix. This person did not turn out to have acute appendicitis, and there was just a little bit of fluid in the lumen, probably about 1 millimeter worth. So again, that 2.6 number that we really start worrying about this sign when there is a little bit more fluid in the lumen than we see in this case. Here an example where it didn't quite work. This was a patient who came in for some totally other purpose, and we saw this appendix that was quite distended with airless fluid, and on the basis of that, questioned whether the patient could have acute appendicitis. This patient turned out not to, so that 1% of cases where you're going to see it just incidentally. But I think it's an unusual enough occurrence that when you see this, and this is what we did in this case, you are sort of compelled to get in touch with either the patient if they're still there, at the scanner, make sure that they don't have abdominal pain, fever, any symptoms that could be referable to appendicitis, or get in touch with the referring doc and just make sure that somebody takes a look at the patient and that they are indeed okay. Now, signs of perforation, because this is the second question that we're trying to answer, not just does the patient have appendicitis, but is it complicated? So these are the two common definite signs of perforation that we look for on scans. In the first image, we see the appendix marked by the arrow and then a little dot of free air. So this patient has perforated. We, of course, also see fat stranding around the appendix. In the second image, we see an abscess. These are our two gold star signs. You see this, you can be very confident in the setting of appendicitis that you're looking at a complicated perforated case. These are also great signs of perforation. You just see them a little less commonly, but occasionally, so keep an eye out for them. Seeing wall necrosis, we actually see pneumatosis in the wall in the first image, or in the second image, and a defect in the normal enhancement of the wall, both great signs of perforation when you do see them. So they get gold stars too, you're just not going to see them quite as commonly. And then there are some softer signs of perforation, things that, you're not 100% sure that that patient has perforated, but it should make you consider it. One of those is seeing regional ileus. So we see dilated small bowel loops here, adjacent to an area of inflammation in the right lower quadrant. The patient did have appendicitis. We were just trying to determine if it was perforated. When you start seeing inflammation that's severe enough that it's causing reactive ileus and adjacent bowel loops, that often indicates that the patient has perforated, even if you don't yet see free air or abscess. Similarly, just the extent of inflammation. So here we see inflammation that is phlegmonous, or in the second case, just really a large amount of free fluid and stranding around this very dilated appendix. I tend to think of periappendiceal fat stranding and inflammation sort of as a continuum. You're usually going to see some in cases of appendicitis. If it's just a little bit, chances are it's not complicated. But the more you see, the more inflammation, the more likely that patient has perforated. There's the phlegmon. Cecal wall thickening, similar. So just indicates severe inflammation in the area. So you start seeing wall thickening of the adjacent cecum. This is a sign that the patient may have perforated. The inflammation is severe. Okay, now moving on to our common pitfalls, which is really sort of the meat of this lecture. There are several ways this diagnosis can go wrong. The first is enlargement of the appendix without any of these secondary signs of inflammation that we're looking for. The second is non-visualization. We just can't see the appendix. And the last is the scenario where you have right lower quadrant inflammation, but the appendix looks pretty normal, or you have right lower quadrant inflammation, but you just can't find the appendix at CT. So let's talk about the first of these pitfalls, enlargement without secondary signs. And to do that, we have to revisit that number issue that I was talking about a little while ago. What constitutes enlarged? Where are we going to set our threshold for an appendix being too big? Well, first let's talk about what is normal, and then we'll talk about what is abnormal. So the 6 millimeter myth has to be addressed. This is sort of a number that has been ingrained in our collective consciousness, probably particularly so for people like myself that trained a little while ago, that if an appendix is larger than 6 millimeters, it is abnormal. And it's simply not true. That number comes to us from the ultrasound literature. It's probably sort of artificially low due to the graded compression that's used when examining the appendix with ultrasound. But at CT, the diameter of the normal appendix is greater than 6 millimeters in about 40% of cases. So a huge chunk, almost half of cases, it's going to be greater than 6 millimeters in normal patients. Now, we're of course here talking about just an outer wall to outer wall diameter of the appendix. And this statistic of 40% being greater than 6 millimeters does not take into consideration what is in the lumen of the appendix, whether it's filled with air or stool or, just what's going on in the lumen. So a lot of those cases, it may be bigger than 6 millimeters, but it's going to obviously be a normal appendix. It's really only the ones that are biggish, bigger than 6 millimeters, and are collapsed or uniformly dense in appearance that are going to be a little bit diagnostically challenging. So let me show you some examples of what I'm talking about so it's a little bit more clear. This is an appendix that measures 1 centimeter, but it is absolutely unequivocally normal looking. The entire lumen is filled with air. The walls are imperceptibly thin. There's no inflammation around it. You're never going to be like, this appendix is greater than 6 millimeters, so this is appendicitis. You're not even going to think twice about it. You're just going to call it normal. So the size, not so difficult when it is filled with air. But what about this patient? If this patient were symptomatic, this is another 1 centimeter appendix, but we can't really see what's going on in the lumen. It's either collapsed or there's isodense contents in there. Here it becomes a little bit more challenging as to whether this 1 centimeter number is significant or not. So how often does that occur? And if you look at just normal patients, asymptomatic patients, in about 3/4, about 75% of cases, you're going to be able to see some visible contents in the lumen, so air or stool or something that reassures you that it's actually just a big appendix because there's some stuff in there, and it's really a very normal appearance. In about 1/4 of cases, the appendix is going to have that isodense, sort of uniformly dense appearance where it's a bit more equivocal looking. And of that 1/4 of people, the appendix will be greater than that 6 millimeter threshold in roughly 6 to 7%. So if you used 6 millimeters as your cutoff, you would be wrong amongst these isodense appendices about 6 to 7% of the time. Now that's not, maybe the worst statistic in the world, but we don't want to be sending 6 to 7% of people to the OR needlessly when they don't have appendicitis. So we need to come up with another way to deal with these cases. So this is one such example. This was a patient who came in with right lower quadrant pain. We were asked to rule out appendicitis, measure the appendix. This is about 1 centimeter. It's pretty isodense. Can't really see a bunch of air in the lumen or anything explaining that it's about a centimeter big. But we don't see any secondary signs of inflammation. There's no fat stranding, no, wall hyperemia, nothing really going on to say, this is definitely inflamed. So in this instance, so biggish, isodense, no other evidence of inflammation, what is the likelihood of appendicitis? This is a graphic that I use in these sort of tricky scenarios. And I want you to first look over on this side of the chart and notice that this is where that 6 millimeter number can be useful. Not as an upper limits threshold, but if the appendix is less than 6 millimeters and there are no secondary signs of inflammation, the likelihood of appendicitis is 0%. So below that size threshold, nothing else going on around the appendix, no wall hyperemia, nothing like that, you can be confident that the patient does not have appendicitis. On the other side of the little algorithm, an appendix that is greater than 9 millimeters, so essentially we're talking about 1 centimeter or larger, no secondary signs of inflammation, no fat stranding, just like that case we just saw, the likelihood of appendicitis is about 50%. So that's really a very equivocal scan. It's a 50-50 chance of appendicitis when you see those findings. In the middle, a little bit hard. There's some, incidence of appendicitis, but less likely. So that's a bit tough. It's hard to make a definitive diagnosis when you're telling the surgeons, it's a 50-50 chance of appendicitis. Fortunately, in clinical practice, most cases are going to show some evidence of inflammation, but those secondary signs can be subtle, so we really do want to look for them. This is an example, another 1 centimeter appendix. If that were all we saw, no secondary signs of inflammation, all we could tell them is this is about a 50-50 chance of appendicitis if the patient is symptomatic. But if we look carefully here, we see just a little bit of fat stranding next to this appendix. Just seeing that little wisp in the fat there is going to push the likelihood of appendicitis here from about 50% up to something much closer to 100%. So really look for those subtle signs. I know these images are a bit pixelated because I've magged them up so much, but just to sort of prove the point that these appendices also look different, a normal versus an appendicitis, if you look at them very carefully. So these are both 1 centimeter. They're both like reasonably isodense. But the normal, we don't see the wall well. We don't see stratification of the wall. In the case of appendicitis, you're actually seeing a little bit of wall edema, that halo sign, that hyperdense, hyperdense layering of the appendiceal wall. That's a sign of edema, of inflammation. That is evidence of appendicitis. Okay, so moving on to our next common pitfall, non-visualization. Sometimes just looking at the thinner sections can help. If you're reading on the 2.5s, go to the 1.25s. It can help tease it out. Looking at the coronal reformation, sometimes you'll be able to see it when you can't on the axials. But the truth is that sometimes you just can't find it. So what do we do in that scenario where the appendix is not identified? Where there are two possibilities, and I'm going to go down both sides of this algorithm separately. So the first scenario is where you don't see the appendix, but you don't see anything else going on. So no inflammation, no stranding around it, this side of our pathway. Now for a while, studies showed some range of likelihood of appendicitis in that circumstance. But there have been a lot of papers in subsequent years that have all showed exactly the same thing, that if you cannot see the appendix, but there's absolutely no evidence of appendicitis secondarily, meaning no inflammation, no free fluid, no localized ileus, nothing to suggest inflammation is going on in the right lower quadrant, the likelihood of appendicitis is about 2%. And I know that our internal statistics at our institution are similar. Now, radiologists, when they went back and reviewed in those cases, in those studies, the 2% of patients where they missed appendicitis, because they could not find the appendix, they were usually patients that looked like this, where there's a real lack of intra-abdominal fat, and there are many bowel loops crowded in the pelvis. And in retrospect, the radiologists weren't at all surprised that they had missed an appendicitis in those cases. This accounts for most of that 2%. So what that really means is that if you have a patient that does have a decent amount of intra-abdominal fat, if you can see fat around the cecum nicely, and you still don't see the appendix, that the likelihood of appendicitis is probably something far less than that 2% statistic. So it's a very reassuring data point. Basically, if you can't find the appendix, no inflammatory changes in the right lower quadrant, you can really consider that a negative CT. Describe that to the surgeons. They know what that means, and move on. Okay, so let's talk about the third scenario. We've got right lower quadrant inflammation with a normal or non-visualized appendix. This, of course, I'm talking about right lower quadrant inflammation that's not attributable to some other etiology, some other diagnosis that we've made looking at the scan. So here we go down the other side of the algorithm. The appendix is not identified, but here we do have inflammatory changes in the right lower quadrant, and it is a really different number. Up to about 50%, 40 or 50% of these patients will have appendicitis. So this is a scenario that I actually think of more like, appendicitis until proven otherwise. Now, when you see the appendix and it looks pretty normal, so let's say less than 6 millimeters, but there are inflammatory changes in the right lower quadrant or near the appendix, this doesn't happen that often. It's a relatively small percentage of cases when we look at sort of equivocal cases of appendicitis. The data shows that this will end up being appendicitis in about a quarter of cases, which means that, most of them, about 75% of them, it's going to be something else. So here, an example, this is a very normal looking appendix. It was about 6 millimeters. There's quite a bit of air in the lumen, which, might suggest that it's not obstructed, but there was some fluid right around it. Does this make us worried? Is this a 25% chance of appendicitis? Well, first off, you have to look for any alternate explanation. And in this case, the patient did have this clear terminal ileal inflammation. This was a patient who ended up having Crohn's disease. There was just a little bit of reactive fluid around the appendix. But sometimes you can't come up with another explanation. Again, a very normal looking appendix. This was about 5 millimeters. There's some free fluid and stranding right around it. Not really any fluid or stranding anywhere else. This scenario was made a little bit more difficult because this patient was clinically brain dead, I believe, and acting septic. Family was, still sort of wanting to be aggressive. And the scan was done. Is it appendicitis? 25% chance. There was no physical exam to go along with it. The patient was rescanned, I think the next day or, some hours later. The fluid and inflammation had resolved. So I don't have an explanation for it here, but this is one of those 75% of cases that turn out not to be appendicitis. So when do we make mistakes in this diagnosis? So those are the pitfalls, but there are also certain scenarios where we tend to make mistakes repeatedly. So let's look at those. And what we're talking about here in terms of mistakes is either missed appendicitis, so our CT false negatives, or overcalls, so where we don't actually have evidence of appendicitis on the scan and we call it appendicitis. So first, let's talk about missed appendicitis at CT. There's two real scenarios here. One is just we blow it. It's perceptual error. It's there and it's abnormal and we just don't see it for some reason. But I think people also are concerned sometimes that there will be cases where we see the appendix, but sort of assess it as being normal. Something sort of soothes us or tricks us into thinking it's normal when actually it represents an appendicitis. And the most common question I get sort of in this genre is luminal air. Luminal air is often thought to be a reassuring sign. It suggests that the appendix is not obstructed. So will air in the lumen sometimes trick you into calling an appendix normal when there is in fact appendicitis? So we will take a look at that as well. First, perceptual error. This was a case of missed appendicitis. Again, if everyone takes a moment to try and find it, it is right there. So this dilated tubular structure in the region of the right adnexa. And I find that this is like an extremely common error that's made. And in fact, when I've gone back at our institution and reviewed most of the cases of missed appendicitis, over a period of time, virtually all cases were in a young woman and where the appendix was sitting in the right parametrium near ovaries and such. And I think that we just have a little bit of a visual blind spot for sort of cystic or tubular looking things in this area because we're used to seeing ovarian cysts, maybe like big parametrial vessels, fallopian tube issues, so on and so forth. And it's relatively easy to walk by an abnormal appendix in this location. So this is something I've just added to my search pattern in young women. Even if it's not like a right lower quadrant pain case, whenever it's any sort of abdominal pain issue, I always take one last sweep through that right parametrial area before I call a case negative. Now, luminal air, again, I just mentioned that sometimes people like to assume that this excludes appendicitis, but it actually, unfortunately, is not that simple. You can see air in cases of acute appendicitis, and it's actually kind of a surprising statistic when you first look it up, but you actually see intraluminal air in about 30% of appendicitis cases. So it's not even terribly uncommon. The thing is that in most cases, the diagnosis of appendicitis is plainly obvious in these cases where intraluminal air is present. I think you actually tend to see the air most commonly in pretty severe cases of appendicitis. And it's very rare that you're going to have a case where you're debating, is this appendicitis, is this not? And air is going to make the difference one way or another. So here are some examples. Tons of air in this appendix, but it is clearly abnormal. It's humongous. The wall is very thick. It's hyperemic. There's tons of fluid and stranding around it. You're going to call this appendicitis. In every case, you're probably not even going to pay much attention to the fact that air is there, and that's how most of these cases go. I've looked some at the distribution of air in cases of appendicitis, like were certain patterns of air in the appendix more reassuring or more likely to be seen in cases of inflammation. You would think maybe that diffuse air was a benign pattern, or sort of like bubbly stool-like air might be a more suspicious pattern, but it did not, these patterns of air do not discriminate well between appendicitis cases and normal controls. Stool-like air or sort of like air fluid levels settling out are a bit more common in appendicitis, but overall, you just shouldn't use air as a leading factor. You can see it in normals, you can see it in abnormals. It doesn't really help you. Now let's talk about the false positive CTs. And here, again, a couple scenarios where we can go wrong. Number one, there are potential mimics of appendicitis, other things that look like appendicitis. The second category is patients who we call appendicitis on the scan. They go to the OR and they say, no, not appendicitis. So like, the CT false positives. And then there's another group of patients where treatment is deferred. So we call appendicitis on the CT, and for whatever reason, usually because the clinical picture does not fit, those patients do not have an appendectomy. So let's look at these three circumstances. First, beginning with mimics. Here we've got a huge appendix with some inflammation around it. The patient's all sort of like diagonal on the scanner, which tends to have a pretty high pretest probability of something being wrong when the patient's flopping around like that. But I will mag up on the appendix here. You can see quite thick, lots of stranding around it. But if we look at another level in the same patient. This is the area of the terminal ileum and cecum, and we see that the inflammation anterior to the terminal ileum and cecum is much greater than it was around the appendix. This was a case I thought might be Crohn's disease before when the scan was first interpreted, but they were persistently worried about appendicitis in this case, did end up taking the patient to the OR, and this ended up being cecal diverticulitis. Here, a big appendix, fluid-filled. We have a very characteristic looking curvilinear calcification near the base. Now, this could mimic that airless, low attenuation fluid look for appendicitis, but this is very distended, and with that calcification, this is a very classic look for an appendiceal mucocele, potential mimic. This is an interesting one, the appendix quite big, no secondary signs of inflammation. We see the appendix in cross-section twice there. This is a case of cystic fibrosis. We tend to see a lot of cystic fibrosis at our institution. It's a referral center. Patients with cystic fibrosis can develop wall thickening of their right colon, and they also develop really big, thick-walled appendices over time. This is something you're going to see more commonly in adults. So you never want to make a diagnosis of appendicitis in a patient with cystic fibrosis just based on appendiceal size. You will be wrong every time. So patients with cystic fibrosis absolutely have to have signs of inflammation, the periappendiceal fat stranding, the hyperemia, all of that. Big appendix and cystic fibrosis, a totally normal finding. Here, another big looking appendix, stranding around it. We also, if we look carefully, see some evidence of other lymphadenopathy regionally. This was lymphoma involving the appendix. So neoplasm can sometimes look a lot like appendicitis. Another example here, a little bit different, a more cystic look to the appendix, wall thickening, hyperemia, sort of fluid-like lumen, but this was a mucinous cystadenoma of the appendix. And this one a little bit different. So this appendix again looks big. This was greater than 1 centimeter, otherwise looks pretty benign. We don't see any inflammation or anything. This was a patient with cancer, and here I don't mean neoplasm of the appendix itself, but cancer somewhere else in the body, so lung cancer or breast cancer, something like that. And we have found that in about 2% of patients with malignancy elsewhere in the body, you'll just see these sort of like big juicy appendices without much of an explanation. We're not sure what causes this, if it could be some sort of like lymphoid hyperplasia, like appendiceal rebound or something after chemo, but something to keep an eye out for. Sometimes can be an incidental finding in patients with malignancy elsewhere. And then one last mimic I'd like to talk about. So here we see this big dilated fluid-filled appendix. We saw this on the scan, because we know this airless low attenuation fluid is a weird sign in the normal appendix. We questioned whether this patient, could have appendicitis. They did not turn out to have any symptoms, but what are we not noticing? The patient here actually has a large cecal mass, which is the reason the appendix looked like this. It was a little bit obstructed. They didn't have appendicitis yet, but there was fluid stuck in that lumen. So that's another thing that I have sort of added to the search pattern, that whenever you do see one of those airless, low attenuation, fluid-filled appendices, particularly if the clinical scenario wasn't, clinical suspicion for appendicitis, please do look at the cecum and make sure that there isn't some mass there or some clear reason for obstruction. So what about the patients where we call appendicitis at CT, they go to the OR, it's negative? Well, two scenarios here. One is we just overcalled and the appendix is in fact normal. But there's also this group of medically unnecessary appendectomies that just get called negative for appendicitis at surgery, but can be a little bit tricky at CT. We'll take a look at those. The negative appendectomy rate of 2 to 3% is probably the true statistic that we should be sort of measuring ourselves by as radiologists. We tend to overcall appendicitis at CT in about 2% of cases. You'll sometimes see higher negative appendectomy rates reported in the literature, the surgical literature in particular, but those refer to cases where they go to the OR on the basis of some clinical suspicion of appendicitis, regardless of what we said at CT. So we might have said, we don't think this is appendicitis, we think it's, Crohn's disease or whatever. They go to the OR anyway. If we call appendicitis, the negative appendectomy rate is about 2 to 3%. So let's look at some of these negative appendectomies. These were two that I saw. So if we look at this case first, pretty normal looking appendix here. It was small. I think that probably what happened here is that some of these vessels in the adjacent fat were mistaken for a little bit of stranding, and this was called early appendicitis, but this turned out just to be a normal appendix, so an overcall. But this other case that's labeled periappendicitis is a pathologic entity where you see inflammation and fibrosis around the appendix, but it does not involve the appendix itself. And sometimes this can be reactive, due to some other cause of inflammation somewhere else in the abdomen, maybe Crohn's disease or something. But sometimes it just happens. This will also get called a negative appendectomy, a medically unnecessary appendectomy. In cases like this, please, by all means, call it appendicitis. You don't want to sort of like fool around and be like, this inflammation looks centered around the appendix. Maybe I'll call it periappendicitis. These are the cases where I'm okay being wrong. And that's probably why that 2 to 3% negative appendectomy rate seems a little bit higher than maybe we would imagine it is. There are some, cases where it's appropriate that we are overcalling it because we do not want to miss cases of appendicitis. Now, the last scenario is one that's really quite interesting. These cases where we see evidence of appendicitis at CT and the patients are not treated due to a discordant or reassuring clinical presentation. So we say it's appendicitis, the surgeons say, no way, does not fit. This leads to some colorful conversations in the reading room sometimes. If these patients are discharged, about 40% of them will return with appendicitis. And I don't mean that they come back the next day, still in pain. They will return with appendicitis sometime over the next year or so. Mean interval was 118 days in this particular study. When they represent, they then have an increased risk of perforation, more complications, so on and so forth. So what we think is going on here is actually that these are cases of chronic or recurrent appendicitis. No one is wrong. The radiologists are correct that it looks like appendicitis at CT. The surgeons are correct that it does not act like acute appendicitis. These are cases of chronic and recurrent appendicitis. But the correct treatment, of course, is not to send them home and forget about them. It's to do an interval appendectomy, sometime more electively, because otherwise they are going to represent. So this is one such example. So big appendix, there's a lith in the lumen stranding around it. I mean, this is like classic appendicitis. We called it appendicitis. The surgeon said, nope, just doesn't fit. They sent the patient home. The patient came back a year later with perforated appendicitis. The CT scan looked almost identical, except that there was a little bit of free air at that time. So again, when you have these weird circumstances come up where you're just convinced that the scan is appendicitis and the surgeons are convinced that it's not, please suggest to them that this must represent a case of chronic or recurrent appendicitis in that case, and the patient should still have an appendectomy. It just can be delayed. It doesn't have to be in the acute setting. So I'll just finish with a few words about pregnancy. Appendicitis is the most common general surgical emergency in pregnancy. It affects about 0.1% of pregnancies, or roughly 1 out of 1,500. There's no increased incidence of appendicitis in pregnancy. That was something I wondered about. As a resident, just because it seemed like this scenario came up over and over again. It's actually probably slightly decreased likelihood of developing appendicitis when you're pregnant compared to non-pregnant people. It just seems like it happens all the time because it's always such a problematic scenario when it does. And the reason it's problematic, of course, is CT is sort of our mainstay for appendicitis imaging in the US, and we do not want to be doing this and CTing those little babies if we can avoid it. So that leaves us with a couple of options to avoid radiation exposure, and those, of course, are ultrasound and MR. So ultrasound, often used in pregnancy to evaluate patients for appendicitis. In one series that looked at patients over 5 years, ultrasound only had a 46% sensitivity for the diagnosis. In that same series, CT had about 100% sensitivity. Not surprisingly, ultrasound tends to do better earlier in pregnancy. So, first trimester, by all means, it's a good way to try to make the diagnosis. As the pregnancy progresses, it simply gets harder to find the appendix. And in those cases, you're often going to need another modality. It is also, of course, operator dependent. Some people seem to be really talented for finding these appendices at ultrasound. Some people, like myself, less so. So MR is another great tool that we can use, particularly in later pregnancy, to help us find the appendix. This is something that's been used for, probably about 15 years now, enough so that we're getting some good data. This was one meta-analysis. 2 sets of data on this slide. The first set, they excluded non-diagnostic scans, which I think is sort of not how the real world works. In the real world, we do have some non-diagnostic scans. So this second batch left those ones intact, but still really good numbers here. High sensitivity and specificity in the 90s. And look at that negative predictive value of 99%. So, in cases where appendicitis was suspected, we don't see it, really good accuracy. So what do we do? How do we actually scan these patients? We just have a pregnancy abdominal pain evaluation protocol in place. So whether they're worried about appendicitis or something similar, this can just be protocoled easily, even in the middle of the night, and then we can look at it after the images come up. It basically just consists of fast SSFSE or HASTE images, axial, coronal, and sagittal. Just try and get every plane to give us optimal chance of finding that appendix. Good to get an axial T1 as well. If the patient can deal with it, if they can stay on the scanner long enough, not that easy lying on an MR scanner, particularly on your back, if you're like in your 8th month of pregnancy or something, an axial fat set T2 can sometimes be helpful to look for edema. So here's some examples. First, of a normal appendix at MR. We see just this little tiny dot in cross section here, the nice normal appendix, and this little squiggle on the coronal, a nice normal looking appendix. It was very small, had air in the lumen. We were able to exclude appendicitis in this patient. But this turned out positive. So big appendix, lots of stranding in the fat around it, fluid-filled lumen, a case of positive appendicitis in pregnancy. Now, at the very least, even if you just can't see anything on the MR, you can't find the appendix, you're not confident that you can exclude appendicitis, you can sort of figure out where the cecum and terminal ileum are, and if you end up in some rare cases having to do a CT, you can maybe minimize the field a bit to decrease radiation dose. And we've also found that MR is helpful in making other diagnoses in the cases where appendicitis is absent. This was a patient we scanned for suspected appendicitis, and in fact, we found out that they had a terrible pancolitis. This turned out to be C. difficile colitis. And another patient where appendicitis was suspected in pregnancy. Instead, this person turned out to have a small bowel obstruction. Now, we have enough data for MR in pregnant patients that we are starting to do MRs for non-pregnant patients occasionally. And of course, the population where this is most applicable is to children. The data here, even using non-contrast techniques similar to what we do in pregnancy, again, high sensitivity, high specificity, even better than we saw in pregnancy, not surprising because we don't have the sort of, big gravid uterus making things more difficult. Again, they've been able to make alternate diagnoses in cases where appendicitis have been absent. And if the patient isn't pregnant, you can consider giving contrast and have all of the benefits of, looking for the appendiceal wall hyperemia and such. So to summarize my recommendations for appendicitis, first, forget 6 millimeters as a discriminatory value. If you are going to use that 6 millimeter threshold, use it as a lower limits threshold. If it is less than 6 millimeters and no secondary signs of inflammation, that's a normal appendix. Be wary of calling appendicitis in cases where there are no secondary signs. So remember, even with a 1 centimeter appendix, it's just a 50-50 chance of appendicitis if you don't see any inflammatory changes around the appendix. So they're going to have a good clinical story to want to go to the OR just with a 50-50 chance on CT. Remember that sign of airless low attenuation fluid in the lumen of the appendix. It is a good sign, particularly in cases of early appendicitis. Remember that a non-visualized appendix with no right lower quadrant inflammation essentially excludes appendicitis. The likelihood of appendicitis in that scenario is going to be something less than 2%. Luminal air does not exclude appendicitis, but usually inflammatory changes are going to be evident, and this isn't going to confuse us and reassure us that the appendix is in fact normal. And remember to consider a diagnosis of chronic or recurrent appendicitis in those unusual cases where CT really looks like acute appendicitis, but clinical findings are discordant. And lastly, remember MR as being a particularly useful method for evaluating the appendix in pregnant patients. Thank you.